Tonight, we will be debating physician-assisted suicide. Now, to explain how tonight's going to go, the doctors will be debating the question, is physician-assisted suicide a compassionate choice? The debate is going to be professional but casual. Each doctor will have 15 minutes to make opening statements, followed by a 5-minute rebuttal from each doctor. We will then have a portion of time for Q&A so they can answer any questions you may have. So let us begin. Dr. William Toffler is a professor emeritus of family medicine at Oregon Health and Science University, where he practices the full scope of family medicine and taught medical students and residents for more than 34 years. He is co-founder and national director of Physicians for Compassionate Care Education Foundation, PCCEF, a nonprofit organization that promotes compassionate care for severely ill patients without sanctioning or assisting their suicide. PCCEF physicians affirm an ethic-based practice based on the principle that all human life is inherent of value, and that a physician's roles are to heal illness, alleviate suffering, and provide comfort for the sick and dying. He is committed to defending the long-standing medical prohibition against doing harm. He has been a member of the Physicians Resource Council at Focus on the Family for more than 20 years. He has been frequently invited to speak about medical ethical issues at both national and international conferences, and on U.S. television and radio, including NPR, 60 Minutes, Good Morning America, as well as international media in Canada, Australia, the UK, and Japan. He has 7 children and 22 grandchildren. Dr. Peter Reagan is a retired family physician living in Portland, Oregon. His practice included hospital care, surgical assisting, pediatrics, and obstetrics. He went into private practice in Oregon from 1983 to 2011. He is a current member of the Oregon Academy of Family Physicians. Dr. Reagan was interviewed for radio and newspaper during the election campaigns for Oregon's Death with Dignity law in 1994 and 1997. In 1998, he was asked to see a patient who became the first person to use the Oregon law. He wrote approximately 25 prescriptions under the law during the following 13 years and attended 3 of his patients' deaths. Since retiring from clinical practice in 2011, Dr. Reagan volunteered for Compassion and Choices of Oregon, working as one of their national medical directors and participating in public speaking as an advocate for laws similar to Oregon's. He also helped with implementation in states where the practice has been more recently authorized and continues helping to improve access in Oregon. He has written a number of publications which include Common Sense in a Thick Hide, Helen, and Physician-Assisted Death, Dying with Dignity. Dr. Reagan is married to Dr. Bonnie Reagan, MD. They have 2 children who are each physicians, and both children are married to physicians. Dr. Reagan has 4 delightful teenage grandchildren. Dr. Reagan, you will be going first. You have 15 minutes, and your time starts.
Thank you very much. Well, I do want to add a little bit to Bill's introduction because he was also one of my teachers, one of my wife's teachers, and also one of my sons and daughter-in-law's teachers. So we're connected. I'll say, I guess you already know that I wrote 25 prescriptions. 15 of the patients I wrote prescriptions for roughly used the medicine. I only attended 3 of the deaths. That's not because I wasn't willing. It's because other people either didn't want their doctor there or wanted to use the medicine at a time when I wasn't available. Looking back on this, I have really decided that it is not a good idea to argue whether or not aid in dying is right or wrong. And I don't advocate aid in dying. From reading, conversing, and participating, I can describe my experience, and I can offer understanding of what it's like to take care of people who request or contemplate aid in dying. Just for fun, I just finished looking through a large number of definitions for compassion because the way the question was asked is something I hadn't quite seen before. I like it, but I hadn't quite seen it before. Basically, all definitions of compassion contain a couple of elements. One is the ability to understand the position of a suffering human being, and the second is feeling compelled to relieve this person's suffering. I didn't find anything in any discussion about the nature of the relief of suffering. So I really can't tell whether some forms of relief that aren't compassionate. The question was about motivation, not choice of mode. So this definition kind of trivializes the debate, and I didn't find it really helpful when you're trying to decide whether it's okay to be open to aid in dying when a terminally ill patient requests it. So that's about what I was thinking about compassion. I thought it might be more useful to at least check out the other end of the debate question you've asked, which is what does medical aid in dying mean? Because there's a lot of loud controversy about the group of practices called aid in dying, and we really can't talk about it without clarifying what we are talking about. There's getting to be a fairly extensive experience in a form of medical aid in dying that's becoming accessible to citizens of a gradually increasing number of United States. All of the state laws currently are rather similar and have the following elements in common. And I want to spend some time just describing what's happening in the United States, because it's surprising how hard it is to kind of remember or keep track. So aid in dying in the United States can only be considered for people who qualify, and the qualifications are that a patient has an illness felt likely to cause death within 6 months, the person's over 18, the person has mental capacity to make decisions about their health care, and this includes not having a psychiatric illness that clouds their judgment, and the person is a resident of a state with a law that specifically permits aid in dying. The person is required to see 2 physicians who agree that they qualify to those criteria, and most typically this would be their primary care doctor and an appropriate specialist. If either of the doctors doubts the short life expectancy, the patient doesn't qualify for aid in dying. Both doctors need to agree that they see no undue influence from family members around the request. And if either doctor questions the mental capacity of the patient, a psychiatric evaluation is mandatory to determine that the patient understands the question and that the consequence of actions under consideration, and that he or she is not suffering from a mental health issue that impairs judgment. People pursuing aid in dying need to make 2 oral requests for that, with a waiting period, most typically 2 weeks between the 2 requests. They also need to submit a written request. In the United States, all aid in dying laws involve an assumption that the patient will ingest the drugs intended to help them die. In virtually all cases to date, this has been interpreted that the dying person will voluntarily and actively introduce the drugs into their own GI tract by some means. Therefore, the specific role of the physician is to decide whether to prescribe self-ingested life-ending medication. They may also help the patient access their GI tract, for example, with a feeding tube if their disease makes oral ingestion impossible. They are not allowed to put the medicine in the feeding tube. In some other countries, for example, Canada, Netherlands, and Belgium, aid in dying laws are somewhat different. First, the deciding criterion for qualification is incurable, intractable suffering rather than terminal illness. And second, IV administration of life-ending medication by a doctor, which is known as voluntary active euthanasia, is permitted. In these countries, it turns out that almost all patients do select that route, IV administration. In the United States, this choice is not legal. I'd like to restrict the rest of my talk to discussion of the legalized practice in the United States, because that's the only clinical experience I have, so it's the only area where I really know what I'm talking about. First of all, why do I use the term aid in dying instead of physician-assisted suicide? There's been a lot of brouhaha over the decades about this choice, and the brouhaha has become extremely political. And I don't care personally what terminology gets used, but I'm going to describe a couple difficulties with the suicide terminology just to acknowledge them. Difficulty number 1, all current U.S. laws state that an aided death or an assisted death is not suicide. Most people have had some experience with suicide, and it's awful. It's clandestine. Friends and family find out about it after the fact, and they're usually filled with guilt and regret. If only I'd called them, helped them, been there, seen them, etc. Suicide is usually associated with personal depression, often a recent loss or defeat, and since the person in question has died, there's no opportunity for family and loved ones to resolve unfinished business. Suicide terminates a life that otherwise could have had a significant future. Suicide is experienced as tragic and often has tragic further consequences. Aid in dying is the opposite of clandestine. Its main virtue is that an aid in dying request is an invitation on the part of the ill person to discuss his or her end-of-life questions, fears, and plans. Caregivers and significant others can try to talk the patient out of it. By the time an aided death occurs, there's plenty of opportunity for issues and other unfinished business to be laid to rest. The dying person does not feel that they are losing potentially meaningful life. From their point of view, they are not shortening their life, they're shortening their death. So how does a typical aid in dying case proceed? After a patient makes a request to a doctor, the doctor needs to decide if he or she is willing to consider writing a prescription for the patient. Considerations will have to include whether or not the patient qualifies and whether the doctor feels he or she is morally okay with possibly acceding to a request. However, the doctor will also want to get a much better understanding for the individual situation because writing an aid in dying prescription is obviously very serious. This means the doctor will spend quite a bit of time discussing with the patients their thinking on the issue, talking with the patient's family, other care providers, friends, hospice workers, sometimes clergy, other involved physicians, not just about the clinical qualifications, but also about the social setting and the meaning of this choice to the patient. After the legally prescribed request and consultation process is complete, the attending doctor may choose to write a prescription for the patient. When the doctor writes a prescription, he or she is not suggesting that it's time for the patient to die. It simply provides the patient with a tool which immediately helps them reach the peace of mind that they're searching for. It's always the patient's choice when or whether to use the medication. And in the meantime, doctors and family will try to minimize discomfort, optimize quality of life for terminally ill patients. And in Oregon, almost all applicants for aid in dying are under hospice care. In Oregon, about one terminally ill patient in 10 inquires about aid in dying, but only about 1% follow the legal process to the end and get a prescription. Of this 1%, about half of them will eventually choose to buy the drugs and use them, and the rest die without using the meds because a natural terminal event happens before they feel the need to use them. Perhaps because of expense, it's very rare that patients actually fill their prescription and then choose not to use it. And that means that very few people have lethal drugs lying around, and it's hardly ever necessary to work on a disposal plan. The doctor is required to report all aid in dying prescriptions to the Oregon Health Division using a prescribed form. Since the clinical discussion around each case involves family, caregivers, all other medical providers, hospice workers, etc., there are many eyes on each case and many opportunities to detect any aid in dying events that do not fulfill the requirements of the law. And anyone at all who is aware and concerned about an individual case can report an irregularity or a concern to the Oregon Medical Board. Cases brought before the Oregon Medical Board are in public record. Just to point out that in 22 years that aid in dying has been legal in Oregon, not one case has ever been brought before the board by anyone. So what are the advantages, if you want to look at it that way, of aid in dying? Well, it's a predictable timing, and that means people can prepare for it, and friends and family can attend, and there's opportunity to settle affairs. It's comfortable. The patient's true fears, concerns, beliefs, and hopes can be discussed openly instead of being clandestine, and the timing is chosen by the patient. Are there some disadvantages? Well, of course there are. One of the disadvantages is that it's a fairly sudden event, and that can be jarring to family members and even to providers. Are there complications? Of course there are. All medical interventions can have complications. In other words, they might go not quite as envisioned. While aid in dying with oral medication in the United States is quite effective, prolonged dying events do occur, especially associated with recognized risk factors. And the possibility of this needs to be discussed and taken into account. Well, what if a wrong prognosis causes a person to die too soon? While it's certainly true that prescriptions are sometimes written for people who then go on to live longer than 6 months, obviously people don't choose to use the drugs until they feel their meaningful life is over. Of course, there's religious objections of various forms, including the obvious example that perhaps the person wouldn't go to heaven, so family members won't be able to hope to be reunited after death. I actually counseled one patient with family objections like that and personally persuaded her not to use the Oregon law. So I have found in my practice over the years a small subgroup of people for whom aid in dying was clearly what they wanted. In that group, family and friends have usually expressed frustration at how cumbersome the process is, but generally appreciate the eventual outcome, and I've never experienced a family who reported regretting a decision. Most terminally ill people don't bring up aid in dying. I mean, stop and think about it. Many people actually die without even noticing their own deaths. I invite you to think about how you might make decisions for yourself or how you might try to be supportive of the people who are terminally ill, regardless of whether they express interest in aid in dying. There's certainly no perfect way to die, and different people will be happiest with different choices. Now I'll return a little bit to the opening question about whether being open to aid in dying is in fact compassionate. Who even should make the choice about whether it's compassionate? And compassionate choice for whom? Are we talking about the patient or the family or the caregiver or even society? I don't know how to find out if something is compassionate without asking the recipient. In this case, the patient is dead. Of course, before they die, these people have clearly stated what they want and have performed the act themselves with their loved ones present. So really the only people you can ask are family and providers. Multiple studies of grief after aid in dying have been done in various jurisdictions worldwide. Reviewing these does not suggest important differences between grieving an aided death compared with a natural one. This is corroborated by very recent unpublished data from a study from Hospice by the Bay, a large California hospice practice, who interviewed 71 of patients' family and friends from aid in dying cases and compared them with similar people associated with more typical hospice deaths and found no evidence that grief was more complicated in settings where aid in dying occurred. Doctors providing aid in dying are less well studied. No questions that some doctors are surprised by their own reaction to providing aid in dying, others are not. I personally was in the surprise group, and the suddenness of it made me stop and think. Did not prevent me from writing more prescriptions later, but it certainly prevented me from ever becoming casual about it. To summarize, I do not advocate aid in dying. I do, however, value the ways in which legalization has improved discussion among all of us about the end-of-life issues. I also value the peace of mind provided for people who have been fearful of potential pain and indignity they associated with death and requested aid in dying. I have personally experienced many patients and families who report enormous relief once their aid in dying arrangements are made, regardless of whether they end up using the option. A classic line is, "Now I can appreciate life again." I have not experienced circumstances in which a death has occurred before I thought it was appropriate or reasonable. Thanks.
Thank you, Dr. Reagan. Dr. Toffler, you're next. You have 15 minutes.
Great. Well, I'm pleased to be here, and I'm particularly pleased to get to be reacquainted with Bonnie and Peter. Bonnie and I actually played roles in skits, senior takeoffs, because at one time my gray hair and curly hair looked like hers, and we shared wigs playing each other's parts. So we had some really great times, and I'm actually not at the university any longer because my diversity is no longer tolerated there. So the reality is that at one time when Peter and Bonnie were there, we prided ourselves that there were people like Peter. Peter Goodwin actually was the person who was first public in the state of Oregon about assisted suicide. And we're not only on the same university, we're in the same department, we're in the same floor of the department. That's where we were. And in the recent years, my contract was not renewed, and primarily because there were many people who didn't like my point of view, anonymously complained about it. And so this is one of the dangers of a paradigm that's being imposed in some cases, and where you say it may not be imposed yet in a sense of I have to do this, that is happening in Quebec where people have to refer. But I'm grateful to the organizers of the event, and I very much appreciate the opportunity to share a counterpoint to my colleague Dr. Reagan's opinion and practice. Too often in our polarized society, we don't really have a chance to hear one another and have respectful dialogue about life and death issues and the consequences of what clearly are profound changes in the practice of medicine. At one time, when I first started medicine, this was an inherent conflict of interest to be promoting the early death of patients. I'm also grateful to all of you here tonight because you're here hearing the opening points of view, and you're going to have attempts to dialogue with us So thank you. It was legalized over 25 years ago and went into effect, as Dr. Reagan said, in 1998, with him being the one that actually gave the first prescription. I think the patient was Helen with breast cancer. All right, thank you. So, but I believe that there's new fear and secrecy on the part of many people, and I'll share some examples of that. Well over 1,500 people, the latest report hasn't come out quite yet, it usually comes out about now. And so we know there's well over 1,500 people who've ingested massive doses of barbiturates, morphine, cardiac medication, and tranquilizers prescribed under the law. The proponents claim the system's working well with no problems. This is being proclaimed all over the country as well as over the world. In Australia, it was in Canada before it was enacted. They actually looked at our law, by the way, and they said, you know, this isn't a very efficient way to do this. And they have IV. All but 5 patients in Canada, as the latest report, some 13,000 patients have been injected with the deadly drugs of a sedative, a tranquilizer, and then finally with a muscle paralyzing agent, which are the same 3 chemicals that are used in the death penalty. As a licensed physician who's practiced in Oregon for over 40 years, I have firsthand how the law has changed in the first half of my career and the second half. In one such case, a patient with bladder cancer contacted me, and she felt she was being steered toward assisted suicide. She was concerned that an oncologist treating her might be one of what she called a death doctor. She questioned his motives and was particularly worried about it after she obtained a second opinion, which was more hopeful than the first. Now, regardless of whose opinion was correct, the idea of not trusting your doctor about the opinion was not something that I saw as an issue before the passage of the law. Under Oregon's law, a patient can request lethal drugs only if she has a terminal illness and less than 6 months to live. However, as Dr. Reagan said, it's nearly impossible to predict the course of an illness 6 months out. Many patients given such prognosis live for rewarding lives for not only more months than that, but years. Of note, the Oregon Health Division recently clarified that the 6-month criterion could be applied to a person with chronic diseases such as insulin-dependent diabetes who decides to stop using insulin. This is a written opinion by the Oregon Health Division. Proper use of insulin allows diabetics to live long and productive lives, like the Reagan son, who is clearly that. Productive, bright, brilliant, and literally now we have a mechanism that's sanctified by the state to end your life. If you stop using insulin, you would then qualify for assisted suicide. In fact, on the latest report, 2 of the patients who ended their lives, the diagnosis with diabetes. The law requires that patients be referred for psychological examination if the doctor suspects they have depression or mental illness, but some doctors see suicide as the solution to suffering and depression, and it's rational given the patient's circumstances. Last year, only 3 out of 249 patients who were given lethal doses were referred for a psychological exam. At the same time, a 2008 study by one of our colleagues at OHSU, Professor Linda Ganzini, said that after examining 58 patients who were in the process of getting the assisted suicide paradigm enacted, 26 of them met the criteria for major depressive disorder and 22% for anxiety disorder. None of those patients had been diagnosed with or referred by their doctors for their underlying psychiatric disorder. 3 of the depressed individuals received and ingested the lethal drugs within 2 months of being interviewed. The study's authors, now this is a person who claims to be neutral, Linda Ganzini, the Oregon law may not adequately protect all mentally ill patients. Indeed, this was particularly true in the case of Michael Freeland, a patient with lung disease who had a history of depression for over 40 years. He called our organization Physicians for Compassionate Care, confusing us with the so-called Compassionate Choices group that actively promotes assisted suicide as a solution to some suffering. He wanted to help in accessing assisted suicide. Rather than simply responding to the content of the request, our staff member who answered the phone reflected back to him, "You must be hurting. Tell me about it." She heard he was in physical pain and wanted to end it all. Rather than helping him with the content of his initial request for suicide, she connected him with one of our pain management specialists who indeed helped him to alleviate the initial pain. I can tell you the specific details of this case because he subsequently allowed the entire medical record to be made public, which is the only case in over 21 years where all of the medical details can actually be reviewed. The rest is hearsay. Despite having pain relief, Mr. Freeland continued to experience periodic depression and was able to obtain a lethal overdose from another doctor. Later, during a cycle of severe depression with suicidal and even homicidal thoughts, he was admitted to St. Vincent's Hospital in Portland. I could actually tell you the details. Again, he's given us permission. He was forcibly admitted because of the suicidal ideations. Because of the thoughts of killing others, police were sent to his home. They found 30 weapons and thousands of rounds of ammunition. They also found a lethal overdose of medication. While the police removed the weapons and ammunition, they left the overdose for Mr. Freeland to kill himself. The hospital psychiatrist acknowledged this in the discharge summary and wrote, quote, "Follow-up may be a moot point," end quote, referencing his possession of the lethal overdose. In the past, discharging an actively suicidal patient would have been considered medical malpractice. In Oregon now, some psychiatrists believe that some situational suicide is acceptable. Mr. Freeland lived for almost 23 months after he first requested a lethal overdose. In fact, he had to have the prescription refilled as it had expired. He ultimately died at home peacefully, without pain and without taking his life with an overdose. The last phase of his life was made possible by the compassionate and caring response of our staff volunteer almost 2 years earlier. During this time, Mr. Freeland had been able to be more functional with less pain and have his depression treated and relieved. Furthermore, during this time, he had reconciled with his previously estranged daughter, who was able to be with him when he died. Beyond individual cases like Mr. Freeland, I'm concerned about the regular notices I receive indicating that many important services and drugs for my patients, even some pain medications, will not be covered by the state's Medicaid program. Yet physician-assisted suicide is 100% paid by our collective tax dollars. Mrs. Barbara Wagner, a retired school bus driver, was just such a case. Mrs. Wagner had recurrence of her lung cancer. Both Mrs. Wagner and her cancer doctor wanted to use the drug Tarceva. Tarceva wouldn't have cured her cancer, but statistically would have given her a 45% increased chance of being alive in 1 year. Because Mrs. Wagner was on the state Medicaid program with a poor prognosis, she received a letter denying her coverage for this life-extending treatment. In the same letter, she was offered full coverage for symptom management for pain, including assisted suicide. Apparently, the state also believes that the solution to some suffering is to end the life of the sufferer. Supporters complain, as Dr. Reagan did, that it gives patients choice, but what sort of choice is it when life is expensive, but death is free? Another problematic aspect of assisted suicide is that the shroud of secrecy envelops the practice. 21 years ago, the law was changed, making it illegal for doctors to accurately report the actual manner of death. Instead, they're required by state law to fabricate the death certificate in the sense of calling it natural when it was actually an overdose, a deliberate attempt to end your life, which is defined as suicide. Furthermore, since assisted suicide was legalized, the state legislature implemented a system of 2 different death certificates, one that's public and includes no medical information, and another that's kept private by the state. As a result, no outside investigators can review or research the practice. Accurate tracking has been made impossible. Reporting is primarily second or third hand by the involved doctors, as 84% of the time they aren't present at the time of the suicide. After these reports are received by the state agency, the information is extracted, and then the reports are actually destroyed. Destroyed in the name of confidentiality, really secrecy. After all, what other area of medicine are records actively destroyed? In my practice, more than 4 dozen patients have discussed assisted suicide with me. Most did not have a terminal diagnosis, including one last year. He wasn't dying, but he was despondent over having lost his wife of 58 years only days before I'd seen him. Rather than providing him an overdose, I spent 45 minutes comforting and one of his daughters over their huge loss. Because of his severe despondency, I asked him to follow up with me the following week. His desire to actively end his own life with Oregon's assisted suicide law turned out to be totally unneeded. As often happens with the loss of a spouse after such a long and successful marriage spanning almost 6 decades, he died of natural causes without having to kill himself within days of his wife's passing. Another inquiry came from a patient with progressive form of multiple sclerosis. He was in a wheelchair, yet lived an active life as a general contractor and had a daughter with whom he was very close. I asked him how the disease affected his life. He acknowledged that MS was a major challenge and told me that if it got too much worse, he might just want to, quote, end it. I told him I could understand his fear and frustration, and even his belief that assisted suicide might be a good option. I also told him that should he become weaker or sicker, I would work to provide him the best care and support available. No matter how debilitated he might become, I told him that I believed that his life was and would always be inherently valuable. As such, I said that I would not recommend nor would I participate in his suicide. I added that I suspected his daughter, were she here with us at that time, would probably say the same thing. He simply replied, "Thank you." In this case, as in the case of Mr. Freeland, the way a physician responds to a patient's request for lethal drugs has a profound effect on their choices and their view of themselves and their inherent worth. Such patients deserve a doctor who will support them through their illnesses, not a doctor who will offer them a quick exit. One of the most troubling notions I hear is that killing oneself with sleeping pills is, quote, dignified, end quote, as if natural deaths aren't. It's over 5 years ago, my wife Marlene died of metastatic cancer, leiomyosarcoma of the uterus. We'd been married for 40 years. The final 5 years, we both knew she would inevitably die of her cancer. At one point, doctors told her that she had 3 to 9 months to live, yet thankfully she lived 4 more years after that incorrect prediction. While I treasure all of our years together, the last years of our marriage were among the best. There was great suffering, but there was also great joy and meaning in the special moments that we and our 7 children shared together. Moments that became all the more special the closer we came to the end of her life. I wouldn't trade a nanosecond of those last years. She died peacefully and naturally at home, surrounded by her family and friends. She never took an overdose, yet her death and life had great dignity. While many believe assisted suicide is meant only for individuals who are really terminal, like my wife Marlene, there's an inevitable expansion of the law. The initial, quote, safeguards, end quote, to protect patients are being challenged and stripped away. At first, safeguards are embedded in the law to reassure the public. Then the promoters attack the safeguards, calling them barriers to accessing assisted suicide. Just last year, promoters of assisted suicide succeeded in having the Oregon legislatures eliminate the 15-day waiting period. Their concern was that a patient might actually die naturally before they had a chance to actively end their own life. One page. They also petitioned the legislature to change the meaning of the word ingest to include deadly drugs given intravenously, rectally, or even by inhalation. Again, the idea was to get the law passed, then change it to make it less restrictive. Ultimately, it will follow the course it has in other countries, initially for hard cases, and then to normalize it and to include assisted suicide even for those who are depressed. Despite these realities, there are encouraging signs as more people in our country become aware of these problems. Dozens of ballot measures to legalize assisted suicide have been promulgated, and many assisted suicide bills have been introduced. Despite passage of assisted suicide in 9 states and the District of Columbia, both ballot measures and legislative proposals in other states have been rejected. In some states, like Utah, have actually passed laws strengthening protection by increasing the penalty for engaging in assisted suicide. As a society, I believe we should continue to reject the legalization of physician-assisted suicide as the solution to suffering. Instead, we must work to increase access to hospice and palliative care to better support those suffering from terminal illness. The sick, aging, and debilitated of our country deserve better than Oregon's law.
Thank you, Dr. Toffler. Now, each of you will now have 5 minutes for rebuttal. Dr. Reagan, you will be going first.
Okay, thanks. First of all, Bill, I really appreciate you bringing up your personal story and respect how difficult and moving and poignant that must have been and must still be. I guess I would like to comment on a few areas where I just want to clarify some of the things that you said. First of all, I couldn't agree more with the whole concept of equating death with dignity with aid in dying being crazy. I totally disagree with that, just like you do. I've seen very dignified deaths that did not involve medication. The slippery slope is an interesting empirical question that is under investigation, right? In Oregon, just to clarify, however, you're right. The 15-day waiting period is now waivable for a very specific category of people, which is the group who the doctors feel, in fact, have less than 15 days to live. So it's not like it went away. It just went away for people that are in a specific clinical category where the doctors actually thought you're probably going to die in the next week or so, which is actually a little easier to guess than the 6-month prognosis. The prognosis issue in general is complicated. Nobody is good at figuring out when, who's going to die in 6 months and who's going to take 8 months or even 17 months. Now, this is an experience you might not have had before. I'm sure you've presented Bruce Freeland or Michael Freeland's case before, but you haven't presented to the person that wrote the prescription. That was me. So Michael Freeland became my patient because he specifically wanted to inquire about aid in dying from me. He also had an oncologist and a primary care doctor, and he wasn't really the least bit interested in talking to me about palliative care. He already had this palliative care that he didn't want to talk about with me. He and his daughter came in. I spent an hour and a half with them, and then I spent another hour and a half a few months later, and then I spent another an hour and a half a year later. He, his daughter was there each time. I would say mental health issues. He didn't tell me that he had any. I didn't know that he had major mental health issues. He was about my 4th case. Do I feel perfectly proud of everything I did with him? I wish I had discovered that he had the mental health issues that he had. Now, all of that said, I find a number of things about his case to be fascinating, and I'm looking at this from a different point of view than Bill is. Michael Freeland, in the middle of having his aid in dying drugs on hand, because way back then it was really cheap and a lot of people just bought them and kept them, he had them, and all those guns. And when he made his suicide threat, that was a suicide threat. He threatened suicide because he wanted to threaten suicide. He didn't want to take the medicine and die. He wanted to threaten suicide. And so he did. They took his guns away and left his medication there, but he didn't want to die right then. He wanted to threaten suicide. It just sort of showed you that there was a significant, intriguing difference between suicide and using medication to die at the end of one's life. Because he wasn't really uncomfortable, really at the end of his rope at that point. I'm incredibly grateful ever since for the care that he got through your organization at the end. I think he deserved it. I'm really glad he got it, and I'm really glad that he died the way he did. I also feel, at least, okay, so one more piece of this story. This whole case was discussed at a psychological meeting in Washington, D.C., and it became quite public. And during all of that, I got calls from his family abjectly apologizing for us being so, whatever you want to call it, defamed around it, and deeply appreciative of the role that we played in his care, and saying that part of how he felt better, at least during the phase that he was with us, was that he had the medication and knew that he was in control to that extent. Okay. A couple of your examples involve people who obviously wouldn't qualify for aid in dying and wouldn't get it in Oregon or any United States state right now, like the despondency case and the MS case. I think the bottom line is the prognosis thing. I'm just going to say we are trying to define a small group of people who would qualify. The qualification is not you will die in 6 months. The qualification is that 2 doctors believe that you're more likely as not to die in 6 months. So that's a different qualification than a prediction. It's just if 2 doctors agree, then you qualify on that criterion.
Thank you, Dr.
You bet.
Dr. Toffler?
Well, it's actually a joy to be on a stage with Peter because I think he has more integrity. I've known that for the last 30-some years we've known each other. And the number of doctors that could do what he just did is say, I regret something and I realize that everything wasn't perfect in retrospect, is unusual. I do not find that among all the people promoting this paradigm. Some say nothing has ever gone wrong, when indeed the shot of secrecy there that doesn't allow you to see what's gone wrong. Now, because we have our ear to the rail of Physicians for Compassionate Care, we have to share the anecdotes that have come to mind. There was a nurse-assisted suicide in the state of Oregon. Now, this is supposed to be doctor-assisted suicide, or doctor death with dignity. And also, I appreciate Peter also recognizing that this has nothing to do with dignity. Now, you may have to say it's a person's choice, so that's fine. You have the choice in every state to end your life. You really don't need my help. I'm not recommending that you go do these things, but there are ways that are 100% lethal. That's why we all have carbon monoxide detectors in our homes to end your life. Again, I'm not recommending this. But the notion of bringing doctors into it, I think, had to come from the mantle of hard-earned respectability of the Hippocratic tradition, where we would not do harm, has now been undermined in at least 9 states and D.C. and some countries, over half a dozen countries throughout the world. The safeguards have become barriers, and that's being written about regularly by the promoters. And again, Peter's not one of these promoters. He said it himself. He's advocating for the patient. I think I heard you correctly. And so we disagree about how we advocate for patients. I'm willing to push back harder than my colleagues, some of whom, like Nancy Crumpacker, had admitted doing 100 cases. The head of medical oncology at OHSU has acknowledged that he's done more of these home visits for assisted suicide. Now think about this. When my wife had cancer, we went to cancer doctors hoping to have things that would extend her life. Every moment was precious to me and my family and my 7 daughters and my grandchildren. And the reality is that you have the head of medical oncology who's now, you can come to me for a cure or you can come to me for hastened death. And he was one of the ones wanting to change the meaning of the word ingest, as Peter said, to be in the GI tract, orally or by NG tube, to be IV. So it's astonishing to me that people say it's circumscribable, because even in Oregon it is not. And I've just given you 2 primary examples. And the conflict of interest, I would not go to a doctor who at some point would feel that my life was just as well over and maybe better, that I'd be helping her by ending her life early. Even if you feel that way, and I've felt that way in my life, even with minor illnesses like the flu, I said to Marlene one time, I said, just get a gun and shoot me. And thankfully she didn't, I wouldn't be here. But that's the content of a request. Behind it, of course, is I feel miserable. And I want somebody who wants to be with me, to be a Mother Teresa to me, not to be Kevorkian, if you will. So how are we doing on time?
1 minute, 44 seconds.
Okay, so the terminology is important. If you do surveys about so-called death with dignity, so-called compassion in dying, aid in dying, I believe in aid in dying. I just don't believe in killing my patients or helping them to kill themselves. That's the King's English. So the AMA has debated this subject for about 3 years, the Council on Ethical and Judicial Affairs, and they have come down firmly that the correct terminology to be most accurate in describing it is them assisting somebody in ending their own life. That's assisted suicide. It's not medical aid in dying. And these are terms that are used because they sound nice. They're seductive. Who could be against aiding the dying? I'm not. So I think it's good that we be clear about our language. We've allowed ourselves to do that and not correct ourselves with our preferred euphemisms or language or whatever you want to call it. And I think that's, again, respectful dialogue, which is, I think we had in the Department of Family Medicine for 30 years. And that's unfortunately changed now. So I appreciate you all being here. I'm looking forward to interacting with you as the audience.
So that concludes this portion. Let's give them a hand. Yes. That concludes this portion of the debate. Again, thank you, Dr. Reagan and Dr. Toffler. As we begin the Q&A section of the debate, I encourage everyone to be respectful and considerate of people's different perspectives. With that being said, as you pose your question, please be brief and straight to the point. Thank you. Hannah, if you can raise your hand and wave. She will have the handy-dandy square microphone to be used to ask your question. So Hannah, if you can scoot over there, so you guys can begin lining up if you have a question.
And feel free to line up behind him as well, if you'd like.
For coming out tonight. My question is as follows, and you both touched on this briefly. The concept of a slippery slope can be used to describe the expansion of assisted suicide. Do you agree with this or not, and why or why not?
Do you want to say something, Bill?
I'd be glad to have you go first.
I think that the question of a slippery slope is empirical. The experiment's being done, and we'll find out the answer. I'm not terribly alarmed in the long and short of it. I mean, are there going to be some individuals that some people feel are going to inappropriately get access to medication? For sure, because obviously some people feel that no one should ever get it. Is there a risk that a person that I might see would be better served by getting medicine if they really wanted it and their family did, wouldn't be able to get it because of because of whatever you want to call them, because of barriers or safeguards or whatever it is that are making it difficult for them to get their medication. I think those are two risks to be weighed. It's not cut and dried either way.
So I think it's a very good question. I think that there are excellent examples of that slippery slope in every country where it's been legalized, and including the examples I gave here in Oregon, where the law is being changed and they're being seen by the promoters as being barriers to access to care. The required referral is happening in Quebec right now as we speak because the access to care. Every doctor should do it. There are literally departments of medicine in this country and leaders of medicine that say unless doctors want to participate in this, they shouldn't be doctors, just like they say about abortion. These are major organizations like the American College of OBGYN, with life at the other end of life. So I'm very concerned about that, of being able to protect your integrity, whether you believe what you believe or you don't. I'd like Peter to be able to have his integrity. I don't think that I have. He has to think like I do, and I hope I don't have to think like he does. I mean, the reality is I believe in the Hippocratic tradition, and I believe that it's an inherent conflict of interest for doctors to be involved in this. I think and the analogy I think it best clarifies it for me. I have a couple son-in-laws that are lawyers. The reality is that you're my lawyer. You're defending me in a capital punishment case. And then I'm astonished at some point because you go across the aisle and now you're actually on the prosecuting team making the case against me. Most people would say that's an inherent conflict of interest. Now, if you don't think that's a conflict of interest, though, you're also the judge deciding which argument is better among the two lawyers, yet you're the same person. And if you don't think that's a conflict, you're also the executioner in a capital punishment case. So again, even if you believe in this, even if you believe in it, it ought to be somebody outside of medicine. And that was the argument that John Kendall, who was the former dean of the medical school, who was a mentor of mine, made at the Oregon Medical Association. If you're going to do this, why are you involving doctors who, for 2,000 years plus, were working on extending, and we were never trying to end people's lives early? For whatever pragmatic utilitarian reasons, it wasn't part of our practice.
Dr. Reagan, I was just wondering the cost of the aid in dying medications to, do yourself in. How much are they? Just real
First prescription that I wrote cost $75. That same drug prescribed the same way now costs $4,000, and so therefore other alternatives have been developed which cost in the range of $500. Incidentally, the same drugs that I prescribed in Europe cost €30.
So when a person chooses to use these, and this is the part that I have trouble understanding, the cause of death is never physician's suicide or physician-assisted suicide. It's a different, and the ethics of that, it just seems so immoral. And how does that work with the insurance companies? Are they working with that too? Because it's probably least expensive for a person to commit suicide than to prefer a longer
Is
life.
that for which one of us, or?
I'll try to deal with this.
Okay, so let's see. First of all, the death certificate is filled out as the underlying illness being the cause of death. The health department, which gets all the death certificates, knows that it was an aid in dying case because they get the report of it. The rationale, which you can argue back and forth about, and I don't care at all, one way or the other, is that a death certificate is a public document. Deaths are public. And the illness is the final cause of death is a public piece of information, but the manner of death, in other words, did you turn off a ventilator? Did you even stop eating and drinking? All of those things are personal choices that are protected. So it is felt to be an invasion of privacy to put on a public document the fact that aid in dying was the final moment. And you can argue both ways about that. I don't really feel wedded to any particular argument about it.
So let me take a stab at it, because Peter had covered some of the ground, but I would say this, that you actually can't find out the natural cause of death on the current statistic unless the family wants to give it to you. There are 2 death certificates. One has no medical information, just when you died and that kind of thing. The other one has medical information on it. And that you are required by law not to use the word assisted suicide or suicide on the death certificate as a doctor filling it out if you participated in that. You're required by law to essentially say what didn't happen is the natural cause, the underlying illness. That's true. The insurance companies actually don't really care. And you made one of the points where it might be a subliminal. I don't think you'd ever have anyone acknowledge that. But just like with Barbara Wagner, continued care with Tarceva would cost $7,000. No, I'm sorry, it was $4,000 a month at that time. The pills, morphine to overdose at that time, as Peter said, were far cheaper. They're now working on cocktails, the DDMP, and different versions of that. That's diazepam, which is tranquilizer, digoxin, a cardiac medicine, and then there's a beta blocker, which is a heart medicine, and lastly, there's a sedative in there. So the reality is those doses are given somewhere between 100 and 200 times the actual recommended dose to start somebody on any one of those medicines. Any one, let alone 4. So the time of death now is shortening from sometimes hours to even days to an average of 3 to 7 hours, I believe, is the latest cocktail they put together. It costs about $500. So the cost of a cocktail, and by the way, this is another thing that's irregular in medicine. The very first animal in which you're trying these things on is the human. That's not what we usually do with drugs and giving drugs. So this is totally outside of the standard medical practice of how we go about deciding what drugs to give. It's all trial and error. And Dr. Blanke is the head of medical oncology at OHSU, was testifying. I heard him testify to this effect just this last year when they were trying to change the word ingest to mean injection. And by the way, both sides were against that. The proponents were also against it because it unmasked the slippery slope. It started just as Peter said. It was all going to be up to the patient, all going to be self-administered. But if you start saying ingest means an IV, generally people don't start IVs on themselves, except in the movies.
Well, it just further exposes the agenda, which there is an agenda here, especially in the state of Oregon, and it seems pretty unethical in some ways. With the death certificate, the cause of death, that just, to me, exposes an unethical situation.
Well, whether you and I agree or Peter agrees it's ethical or unethical, it's the law.
I have kind of a personal question. So I have a brother-in-law that had a 6-month diagnosis. He's 10 years still alive. I also have my husband's dear high school friend, 6 months, who lived 3 years. What is the percentage that doctors misdiagnose that 6 months, especially with what's going on in our country with medicine? Amazing things. My nephew is a cancer survivor.
I don't.
How do we know what's going to happen in 6 months in the medical field that could save these people saying are terminal now, but in 6 months with medicine, how it's going, how do you know that there won't be something that could save them?
Of course you don't. I absolutely agree with that. The whole question is not whether or not, it's not up to us to really figure out for sure this person is going to live 6 months and 14 days and wait a couple of weeks and we'll consider you for a prescription. It's a question of who would we consider, who is it legal to consider giving aid in dying to? And really, aid in dying is not killing in the sense that you are not causing a person's death at a particular time of your choosing. You're giving them a tool that they can use when they choose. And you're right, it is conceivable. In Michael Freeland's case, he could have taken my prescription and taken his drug and lived a year and a half less than he otherwise would have. And that's
and again,
that's a possibility. That could have happened. And in your relative's case, had he at that point, when he was told he had 6 months, said, "Oh, I want to die tomorrow," but then it would have taken him a couple of weeks to get all the waiting periods done, he could legally have done that. You're right. Would he have chosen to do that? Maybe. I doubt it. I wouldn't, but most people wouldn't, but maybe some people would.
So again, Peter and I agree totally. He also said earlier in his opening remarks that we get pretty good at diagnosing death when it gets to the last couple days of life. We're lousy from 2 weeks on. And everybody knows a story like you just told. There's another patient that I didn't talk about that we have been following, Jeanette Hall, who had colorectal cancer. She had voted for assisted suicide. She wanted it when she found out she had cancer. I don't want to go through chemotherapy. I don't want to go through radiation. I'm here just for the pills. But instead of running into a doctor, and I don't think Peter would have done this, he would have done the same thing that Dr. Stevens did. He said, well, tell me about that. And he finds out in the next couple of weeks that he's caring for her, that she has a son going to the police academy. Don't you want to see him graduate? Don't you want to see him get married? She changes her mind because he encouraged her about the things in her life that were meaningful. She chose to go get radiation and chemotherapy, even though she was deathly afraid of her hair falling out. It did fall out, but it grew back. It's now 19 years. 19 years. And she's so glad within 5 years of this happening, she comes and finds Dr. Stevens in a restaurant. He says, "Dr. Stevens, you saved my life. Had you been one of those doctors," and again, I don't think Peter's one of these doctors, but I think there are people who within just a short time, in fact, the average time a doctor who does this knows the patient is down to 10 weeks. It was 12 or 14. Now it's come down. So it isn't a long-standing relationship like I and Peter have had with lots of patients over the years, Bonnie. The reality is these are many times referral people. Peter himself is well above the state average with 25 prescriptions, because if you take the number of 1,500 and divide it by the 14,000 physicians in the state of Oregon, you don't come up with 25, or the other way around. But the point is that you come up with less than one. And so what happens is now you have people who become relatively expert, like Dr. Blanke, who acknowledged he's done more of these than anyone else in Oregon, is what he said. Now, I don't know if he did or he didn't, but that's what he said under testimony, sworn testimony to the legislature of Oregon just this year. So they get to be referral agents. And it's not that personal agent that was described to the people when you were voting on it back in 1994 and 1997. Like, oh, it's going to be people who know you best. We have to have the doctors who really can know it and understand you well. And you see how flawed that is. There are lots of times I didn't know what my patient was really up to when they got prescriptions from me with narcotics and opioids and things like that. I didn't know the backstory. And we've finally kind of reversed that. And so your point about what about cures? In 1995, when AIDS was uniformly lethal within 10 years, there were half of the infectious disease doctors in San Francisco, in peer-reviewed publications and surveys, admitted they'd ended the lives Half of the infectious disease doctors had admitted they'd ended the lives of some of their HIV patients because they had such a miserable prognosis and despondency about that. And within a few years of that 1995 publication, heart therapy came out. Highly effective antiretroviral therapy, which was now a treatment for life, like Magic Johnson, who didn't die of AIDS because a cure came out. So you're exactly right. And again, I appreciate Peter acknowledging that we don't know these things. And that uncertainty is not being shared with the public in general. And if it was, I think there'd be less enthusiasm for this. It's almost like we're supposedly computers and we know exactly what's going to happen, when it's going to happen, and how it's going to happen. And that's, yeah, I think God is right. God with a little g. Yeah, thank you.
So my question is,
Okay, let's see. The chance that someone will take the drugs and wake back up is something like a small fraction of 1%, but it's not zero. None of us have any confidence that that person who wakes up will be in the same state they were in when they went to sleep, although in the very few experiences where this has actually occurred, they seem to have woken up like they went to sleep. So, very, very low. Most people die within an hour or so, and then there's a longish tail. I'd say 4/5 die within the first 6 to 7 hours. And then there's some group that don't. So, yes, this is not 100% successful medical procedure, if you want to look at it that way. And there is no 100% successful medical procedure, and this is included in that group.
So I agree with that as well. It's a small percentage, but it's not zero. There was one case in Gresham, I believe, where the man took the overdose, when it was supposed to do it exactly at the time, with secobarbital, the fast-acting 90 pills, 9 grams. And basically, he woke up 67 hours later, and the first words to his wife, by the way, his wife went along dutifully saying, well, this is what he wants, and this is an attitude that I would like to encourage you to have with me when I feel despondent and want to end my life. But she went along with it, respected his choice. He wakes up 67 hours later. His first words were, "What the hell happened? I thought I was supposed to be dead." He then realizes this is a story that was written in Oregonian. That's the only reason I know this is because basically these things are usually shrouded in secrecy, but they reported in Oregonian, 2-page story. So he has an epiphany and he says, well, God must not want me to die. His wife is elated because she'd gone away with it thinking that was the dutiful thing to do, to go along with his wishes. And so he ended up living for another 11 days and died naturally at home with dignity again, with his wife, with surroundings, all the things that are being sold as what you have to do is take the overdose to have these things happen. So I think that it is sad that, well, I'm glad that he didn't wake up with a stroke because of hypoventilation and hypoxia and all, which could happen. And I think this whole notion of people going along with it, whatever you want, it's okay with me. I'm a vending machine. If you want this thing, I'll help you. It's really not, I don't think, compassionate. That's to suffer with your patient, as Peter's done, I've done with lots of patients, Bonnie's done. That's compassion. It's apathy. What you do doesn't have significance to me. And that was the point I was making with Michael Freeland. His daughter was glad that they had time to reconcile with each other because they weren't always like that. And so it's very hard for us, even though we may know patients very, very well. I would never claim to know that I know them the best of anybody. And so it's very hard, I think, to go along with these things, in my opinion, without compromising and without causing yourself to have a conflict of interest about who are you really for. And whether you're disabled or abled, whether you're with a terminal cancer or not, I think we should treat everybody exactly the same. And I don't mean that I want to prolong life if they don't want it prolonged, they don't want interventions. On the other hand, I don't want to shortchange it because they're feeling despondent, just as I was when I had the bad flu case,
Hi, my question is directed at Dr. Reagan. I apologize because you've been getting a lot of them.
It's fine.
But I'm frustrated because you do seem like a very compassionate person, and you're clearly very intelligent and much more intelligent than I am, but I feel like you're
Don't
in
count on
the
that.
wrong- But thank you. But I feel like that compassion is being directed in an inappropriate way. My question is, if you were in a circumstance like that happens a lot, where there's someone on a bridge who's going to jump, and when those situations happen, the police comes, but also psychologists come. And so in that circumstance, the person who's about to jump explains that they have 6 months or less to live, and that they have all these reasons why they shouldn't live. And then you accept those reasons as, yeah, that seems pretty legitimate. And then you let them jump. How is that any different?
Well, it's not legal. I guess that there's one minor difference there.
It's legal for them to jump, but you're not saying jump, you're letting them jump. In the same way as assisted suicide is letting someone jump.
Well, interesting situation. I guess I feel quite confident, frankly, that if I was in that situation, and I've never been in it, I've never happened upon somebody who was going to jump off a bridge. And I can't imagine doing anything but doing my outer damnedest to get them not to. And no matter what they said, you know what I mean? It's like, sorry, that's not a decision you make on the edge of a bridge. I can't help you make that decision on the end of the bridge. I'm going to try to help you not make that decision. And incidentally, just, oh, by the way, but this is a totally separate conversation, I try to talk people out of aid in dying. If somebody comes to me and asks me for a prescription, what I do is try to talk them out of it. I try to offer them all the alternatives I can think of and tell them all the consultants I can imagine might help them. I ask them about their church and their family support and all of that. If I don't succeed, that's when I start wondering about the other choice. I don't know anyone actually who is being as cavalier as Bill's describing. That doesn't mean there aren't people like that. I just don't know any of them. So compassion is one of those things. Somebody comes to you and says, here's my situation. You get another corroborating opinion from another doctor. You talk to their hospice workers, you talk to their wife, their brother. Everybody's like on the same page of, this person's been talking about this for the last 22 years. This is what they want. At some point, some of those people, it's like, I guess that's what they want. But that's how it feels.
So let me take a stab at personal experience. When I was a misguided medical student, my wife and I had been married for only a year or two in Richmond, Virginia. She went to a doctor, OBGYN, and she requested an IUD, an intrauterine device to put into her uterus. Now, they had just come on the market within a few years. The doctor did not want to do it because he was concerned she'd never had a baby, and putting it in a person who'd never had a baby, he was concerned about her being able to be pregnant and she would be potentially infertile. Because at that time, there was clearly an increased risk of infection, and going through an untested cervix to put it in would be somewhat traumatic, et cetera. I was tweaked a little bit about his resistance and not wanting to do it. But I wasn't tweaked enough that I went to a different doctor or encouraged my wife to go to a different doctor. Now, Richmond, Virginia, for those of you who don't know, was the home of the Dalkon Shield, which ended the uteruses of many hundreds of women, caused infections, and was very much, it rode through, it looked like a fish hook, if you would migrate through the uterus. So the doctor had integrity, as I hope all my colleagues would, when they have concerns about things, and they just don't want to be a part of it. I'm not a vending machine, and I hope my colleagues aren't. And so I think I'm really grateful because we have 7 children, and I'm working on the 22nd grandchild coming out this June. And that might not have happened had he not had the integrity to do what he didn't think was a good idea. And indeed, the IUDs were ultimately taken off the market for several years. I know in family medicine, we were the resource for IUDs for the rest of the campus because we had a stockpile of them. Again, I don't do this stuff anymore, but I did. And I regret now, looking back, at the harm I caused to people. I inserted IUDs in people who were pregnant because we didn't have great diagnostic tests. That was just after the latex agglutination test for pregnancy. So the harm, first, do no harm. And I really believe that it's okay for doctors, whether it's Peter, me, or whatever, anything, to say, I just don't think this is a good idea. And in this issue, I say, I don't think the profession should be doing this. There are people, there are veterinarians, and again, I'm not labeling veterinarians, who know how to do this. It was only a couple years ago that the very first course on how do you do this happened at the OHSU residency. It was after Bonnie and Pete graduated. So for 3 hours, there was no counterpoint. There were 6 people promoting assisted suicide who have actually engaged in it, teaching our residents how to do it, how to access the services. What curriculum time was taken away from that, of how to extend life, of how to take care of really sick patients? I'm bothered by that. Now, not everybody has to agree with me, but I'm bothered about our profession being immersed in that. I agree with Dr. John Kendall, the former dean of the medical school. If somebody's going to do this, it ought to be somebody outside of medicine. So none of us, Peter, me, or anybody, has to anguish over this stuff.
Hi, I'm Bonnie Reagan, and I'm a physician. Bill Toffler was my teacher, and Pete was my teacher in many other ways. And I came at this issue because I was the chair of the ethics committee at Adventist Medical Center when the Death with Dignity Act passed. And all the ethics chairs got together and we helped create a group called the Task Force to Improve the Care of Terminally Ill Oregonians. And we were a neutral group because we represented the stakeholders in the healthcare section of Oregon. We represented doctors, attorneys in healthcare, nurses, hospice, and we worked on the Death with Dignity Act ramifications and implementations as our own group of interested people for 13 years. I have to say a few things about what I've learned from that. First of all, I came at it from an ethics point of view, and I know one of you just brought up ethics. From the people that I know personally who've been involved and chosen not to be involved, because there is conscientious objection for this, nobody has to do this for a patient. I can say that the doctors that I know who've been involved with choosing to help patients with aid in dying have gone through many personal challenges to their own sense of morals and ethics. This is not something to be taken lightly. I have never seen anybody take it lightly. Maybe now some people do, but that you could say that's true of any branch of medicine. I haven't always been taken seriously by my doctors in other ways. Secondly, there's something that hasn't been brought up, and when I gave a talk on this in Wisconsin, which by the way does not have this law, an oncologist came up to me and he said something that really bothered me and still bothers me. This was a number of years ago, and he said, "We do this secretly all the time. We're always giving patients overdoses of medicines for them to take when they get tired of their cancer. Why are you ruining it for us?" I want you to hear that because that's been done for years by certain doctors in every state in the union. What Oregon did was they brought it out in the open so it could be discussed and people could talk about it or not, and people could choose to be involved or not. And that's something that's very important. It isn't like every doctor has always been a person who's only helped people improve their life and extend their life. That is not the case. Thirdly, I want to say something about the people who don't want to wait 2 weeks. My mother was one of them. So my mother had cancer. I know this is unbelievable. She's the only person I know, but my mother dealt with cancer 10 times. She had 6 primary cancers, and she had at least 4 recurrences. She had cancer for over 50 years, and when she died, and she lived a long time. She lived to be 91. She got her first cancer in her 40s. And I wouldn't have believed this except that we went through all of them with her. So when it finally came time, my dad died right before she did, and she did not want to live anymore. She still had 2 cancers going on, and she asked for use of the Death with Dignity Act, and when she heard it was 15 days, she said, "I don't have time for that." She was a pretty straightforward person, and she actually chose to end her life by not eating or drinking, which was perfectly legal. She was 91, she had cancer, and that's what she chose because she did not want to wait that long. There are people who don't want to wait. There are people who push their doctors into working with them with aid in dying. And the bottom line is that there's all kinds of situations, and people struggle. People struggle with their situations, and they bring them up to their doctors, and their doctors struggle with the situations. And I would like us all to have respect for what everybody is going through. Thank you.
Thank you. Thoughts, remarks on any of that?
Well, I as I said, I respect Bonnie and Peter's integrity very much. We don't have to agree on everything in life, and I think the uncertainty about prognosis is a perfect example of her mother with 10 cancers and lives to 91. And so often cancer is the C word, if you will, and it's very hard for doctors to be straight about it sometimes because it has such a heavy connotation. I remember the young GYN oncologist who took care of my wife, Marlene, of how it was very hard for her to say that there was no cure for her cancer if it had spread beyond the uterus. And about 18, 20 months after the diagnosis, we confirmed what one pathologist thought was the case. You know, it's interesting because the pathologist at OHSU said no problem, it was taken out completely. It was a 5.5 centimeter tumor in the uterus, leiomyosarcoma. It spread hematologically, so all the lymph nodes were negative, didn't really matter. Then another pathologist looks at that same specimen that was declared just contained, and he finds a little cancer cell in a venule, a little tiny vein. He knows immediately what that means, is the horse is out of the barn. There is no lethal drug for this cancer to cure the cancer that will kill the cancer. And so, you know, with the pathologist's kind of bedside manner, he says to my wife, well, how do you feel? Well, how do you think I feel when I find out that my cancer has spread and there's no cure for it? I mean, it's like, it's a heavy thing to say. So he let us know, and we were hoping against hope that even though he saw that it wasn't the case. But again, we were blessed with 4 times what the prognosis was. And this is the whole problem. We now have people who say if you're mentally disabled in some way, that's a reason to have assisted suicide. It's not what we said was the original law. And there are other states passing laws that, you know, are not quite as circumscribed as Oregon's original law. And so it's a problem. The voluntary stopping and eating and drinking is a technique any of us can have right now. I don't recommend it again. In other words, why does the government have to be involved in this? And, you know, as far as the secrecy thing, I don't know any doctors myself who've done this. So when people come up and they did to Bonnie and say, this is what we used to do. Yes, there are times I give people enough pain medication that they can actually be on top of their pain. But if you do that in a stepwise fashion, 50% over what didn't work before for the next dose, people actually live longer, including my wife. She was short of breath with metastatic lesions in the lung. She had air trapping. She was absolutely, she was down on blood. We took her to the hospital just desperate. Maybe by giving her blood, there'd be more oxygen carrying capacity. We got the transfusion. It had to be done in the ICU because she was in such distress. It didn't work. She tried turning up the oxygen. It didn't work. But the nurse gave her higher doses of morphine than I was giving her at home, and that relaxed her. We left the ICU less than 24 hours from the time we went there. We went home. She died within 10 days. She lived longer because of more morphine, not shorter. So the myth of morphine is only true if you do it in the DDMP, with M being a morphine, and you're giving 100 to 200 times the normal dose without any background dose. And that one drug could be lethal, let alone the other 4 that you're giving 100 to 200 times. So it's a deliberate ending of the person's life, which is very different than people using pain medicine appropriately. And the double effect is such that if you give medicine with the intent of trying to give the person comfort, and as an unplanned side effect, the intent was never to kill the person, that's actually not unethical. You tried to do your best, and it had a side effect, if you will. That's what double effect means. And so I think it's a big deal if a doctor is doing it deliberately with the intent to end the person's life. That's sad, because it's totally against what all of us took of not trying to do harm to people. And I'm not changing that ethic based on the situation. I believe that it's always got to be primum non nocere. First, do no harm, and then decide stuff.
I'm trying for the prize tonight. I'm 90 years old. Is anyone else here that old? I'm married for 67 years. My husband died at 67 years, 4 years ago. The morphine is something that we need to talk about. I was with 11 people who were on their deathbed, many of my relatives. Took care of my brother-in-law under hospice, my husband. I'm not a nurse. When my doctor's son walked in, and my 6 nurses, and my paramedic, I'm very proud of him. I said, did I give him too much morphine? You know, I gave him prescribed amount with hospice. But it was a wonderful time, and I want to tell you about the wonderful time. Death is a wonderful thing. My people, except my sister, died in 1960. We had no CAT scans, nothing like we have now. We're living with medical science and we're not using it right. I have 66 grandchildren.
Whoa.
I'm worried about every one of them because of the mindset that is told. So easy, just die. Take the cocktail. Sounds easy, doesn't it?
Well, you're a great role model. I'm only at 22, so I need to get lessons from you.
Well, we have 27 grandchildren, and the rest are 60 great-grandchildren. No great. And I'm proud of all of them, but I'm worried about them because they're told a lot of junk. That it's supposed to be easy to take the cocktail. I couldn't have given one to my husband. Drink a cocktail. And
So
die.
you said your husband's death was beautiful, or dying is
beautiful.
Tell us about that.
Oh my goodness. I took care of my brother-in-law under hospice too for 15 months. Well, he wasn't on hospice for 15 months. He had pancreatic cancer. I have a feeling he was a farmer and he had a lot of grit. But I know doctors have a lot of grit too. But he was diagnosed with cancer 4 months before he died. He had had 2 quadruple bypasses. He had prostate cancer. Let me see, what else? Well, anyhow, he lived till 90. He was sick 4 months with pancreatic cancer, did everything, went out and trimmed the roses 2 weeks before he died. Now, maybe this is a good death, but maybe I helped him to have a good death. And with my kids and my neighbors. So he had pain, but we didn't really use morphine till the last day. And maybe you could use it for 6 days. I don't know, doctor, could you?
You can use it for months and even years.
But the kids told me right away, see, I'm just a grandma and I've taken care of 8 kids. And I said, did I give them too much? And they just said, no, that helps. It doesn't hinder. And I didn't know that. I have no RN behind my name. So I'm telling you right now, I'm worried about the future. If I live 10 years, I'll be happy. If I die tomorrow, I will be happy. Because I'm going to leave my kids with something to hang on to. But if we keep telling them the lies, they're not going to get it. They hear it in school. So.
Well, you have an important perspective. I appreciate your sharing that. Thank you.
Well, I really think that we need to, well, my friend called and said, can you go tonight? It's too easy just to stay home. But we've been pro-life forever. We are. These are all my friends here in the row. And thank you, I forgot your name, but thank you for putting on this. And thank you, all you kids who are here tonight. You're the future. But don't let them tell you everything's going to be easy to drink a cocktail. Because death was not bad for the people. I've been with 11 of them, 11 people. And the only time was my sister in 1960. They
You're an
didn't have
encouragement
men-
to all of us, and it's Marcos who, and his cohorts in the pro-life group that put this on so we could have a respectful dialogue. And
Reagan. Yes, I thank you for coming. And I like the discourse. I like the idea that we can talk or forget.
That's a good way to finish tonight. I want to thank Dr. Toffler and Dr. Reagan for their unique insight and perspective. Also, I'd like to thank Hannah Anderson, our Vice President, Chemeketa Students for Life members, and advisors, Chemeketa staff, and most of all, I want to thank all of you guys for attending tonight's debate. If you have more questions for the doctors, they will stick around for a bit longer. So if your question was unanswered, feel free to ask them. The doctors have come free of charge tonight, and for that we're very thankful. It is costly to be active on campus, however, so if you're willing to make a contribution to Chemeketa Students for Life, that'd be much appreciated. A generous donor is offering a matching grant up to $3,000, so if you make a donation tonight, your contribution and your impact is doubled. In the lobby, we have cookies and refreshments, more information about physician-assisted suicide and the Chemeketa Students for Life Club. In addition, tonight's debate might have got you thinking about preparing for the future. So Conclusions Oregon is offering information on how to complete your advanced directive. Finally, I hope you are walking away with a better understanding of physician-assisted suicide and an informed opinion. Thank you so much for attending. Good night.